Right, so today we have Professor Lucy De Silvio to come and talk about the future of reconstruction, which is nothing to do with surgery, which is to do with tissue engineering, growing things from stem cells and with proteins and the like, but you'll hear from Lucy about that. And then we have Doreen, who we'll tell you about, and she's kindly agreed to come along with her husband, and they're both going to sit and answer questions. He's the strong, silent type. He doesn't normally answer questions, but he's going to answer questions tonight. Okay, so without further ado, let's get going. I'm going to whiz through a lot of pictures. They're really just to give you a flavour more than anything else. You've got the handout which covers all the facts, really, and is built on the slides. So, when people talk about reconstruction, the great British author, or one great British author, said that he'd had extensive facial reconstruction, when in fact all he'd had was implants put in his jaws and false teeth put on his implants. Does that count as reconstruction? I don't think so, but it does count as rehabilitation. What I think is, it's not putting in titanium plates, but it is dealing with tissue loss or absence and bringing new tissue in to replace what's been lost. That's my definition of it. History is always worthwhile. So right at the top there you see the Sushruta. The Sushruta is the first written text on reconstruction, came from India about 500 years before Christ, was the first Sanskrit text. You can see copies of it in the Wellcome Museum, and I did a short program with a historian on it on Radio 4 some years ago, when I discovered that what I thought was the first reconstruction was conducted wasn't in fact the first reconstruction was conducted. In India at that time, people who committed crimes had their noses cut off. So there was a roaring trade, and remember there was no general anaesthetic then and no local anaesthetic. They had a roaring trade in reconstructing noses, and originally I thought that they used the glabella flap, which is based on the supraorbital and supratrochlear arteries, and they turned it round through 180 degrees and used that to reconstruct the nose, which is what we do nowadays. Don't pull a face like that. It's fine. They look great. In fact, I was going to ask I did ask a patient who'd had it done to come tonight, but unfortunately he's at his school children's parents' evening, so he couldn't come. So we'll try and get him along another time, so you can see it doesn't look too bad. Anyway, so, but in fact, what it was it was a cheek flap turned laterally, not turned through 180 degrees, turned laterally. So that, and Sushruta was on the banks of the Ganges in a town called Benares or Varanasi, where you can still go today and you can see human beings, dead human beings, having their corpses burnt by the river Ganges and the ashes thrown in. And if you're really holy, you're thrown into the Ganges hole. You're not burnt before you're thrown in. So it's a very interesting place to go, and they do beautiful silk brocade things as well. Tanzini was an Italian who did nasal reconstruction in Italy in the Middle Ages. Kazanjian is somebody who I am particularly interested in. I did a Radio 4 program on him, and he was an Armenian refugee who studied dentistry in America at Harvard and became professor of prosthetic dentistry in Harvard, then went out to look after British troops in the First World War and got a taste for reconstructing faces that had been shot off. Went back and studied medicine and became founding father of plastic and reconstructive surgery in the United States. While over here we had Harold Gillies, who was an ear, nose and throat surgeon working in the First World War, and he was from New Zealand, and he developed techniques which are rarely used today, called bipedicled flaps, for reconstructing the face. And then we had McGregor and Buchangian. And McGregor was from Glasgow. Buchangian was another Armenian. You could always tell an Armenian because they end in IAN. And he was the professor of surgery, reconstructive surgery, in the arsehole of the world. That's what they call Buffalo in upper New York State. Anyway, so he was the professor of surgery there and only recently retired. And he devised a flap based on the perforating branches of the internal mammary artery. Now, the internal mammary artery is actually used for coronary artery bypass surgery, but it sends branches out through the medial aspect of the chest, to supply the skin, and it runs laterally. So you take the skin, a flap of skin going out right to the shoulder, and then you can roll it into a tube and you can turn it up and you can get it to reconstruct either the neck or bits of the face. So those were the first axial paddle flaps. That was Buchanan's contribution. McGregor devised two flaps. He devised the groin flap based on the superficial circumflex iliac artery, which you could turn around, and also the forehead flap based on one superficial temporal artery. And the point about those flaps were they were not random pattern flaps, they were axial pattern flaps, which means they had a single artery pumping blood into them and a single vein draining blood out of them, which means you could take them over a much greater distance. The point about Gillies was, in Gillies' time, we knew about the 2-to-1 rule, which means that you can't raise a random pattern flap which is more than twice the length of its base, because it runs out of blood supply, because it doesn't have a definite blood supply coursing all the way up it. It has a series of millions of little vessels going up it, and they can't survive more than 2 times 1. So that's why he had a bipedical flap. So what would happen is, and I'm going away from the microphone for a moment, what would happen in the leg was, sorry about the hairy legs, so what he would do was he'd make 2 parallel slits, and he'd leave it attached there and attached there, and he'd turn the raw surface round so it would join together. So it would be a tube, and it would be bipedical. He would be getting blood coming from there and blood coming from there. And he'd leave it like that for 3-4 weeks, and then he would cut that end when it was getting a good enough blood supply from here, and he'd turn it up and attach that end to the person's arm. So then it was still a bipedical flap, and he was getting a blood supply from here and from there. And then after 4 to 6 weeks, when he was getting enough of a blood supply from here, he would then cut that, and then he'd put the arm up to here. So the poor bloody patient had to go around like this, and then around like that, while it was waltzed up onto the face. Achieved very good results, but it might take 18 months for the reconstruction to occur. Don't worry, I'm not going to expose anything else of my body. Anyway, so then we come on to a non, as for anonymous. That is the radial forearm free flap, which is based on the radial artery, where you take skin from the arm, and that was devised in China. We don't know actually who devised it. It was called the Chinese flap, no name attached. And Taylor was Iain Taylor from Australia, who devised the first bone flap. And these flaps were actually severed. The artery and the vein draining the flap was severed and lifted off in one go and placed elsewhere on the body, and the artery and vein joined into the neck or into veins elsewhere and arteries elsewhere. The clamps taken off and blood whooshing through. So it was an extension of the axial pattern flap. You have an artery pumping blood in, a vein draining blood out, and what happens then is you, instead of leaving it and just turning it through 180 degrees or 90 degrees, you were able to actually sever it completely from its blood supply and join up the blood supply elsewhere so that it then is moved elsewhere. And obviously you know about the face transplant, and the concept of that is taking a whole face from somebody else with the artery, the facial artery and facial vein, and attaching it to the other person's face and joining it to the facial artery and facial vein of that person, and then getting the blood pumped through and supplying the whole face. Otherwise it becomes a piece of dead meat on a butcher's shelf. So these are the kind of things that we're concerned about with reconstruction. So this young woman who has a very large tumour, benign tumour, which is obstructing her airway and her mouth. She can't eat, she can't breathe, she has a tracheostomy in place. Or noma. This is an infection, cancrum auris, found in Africa in immune-suppressed people. We need to reconstruct that person. That's what I call reconstruction. Here we have the person, those of you I think who came to the first lecture, I think I showed a slide like this, which is somebody who has had radiotherapy to one half of their face and their face hasn't grown properly, and so we want to reconstruct them so that we can get their face looking the same on both sides as opposed to asymmetric. Or this guy who's had part of his nose bitten off and never had it reconstructed. That's tissue loss. So these are, if we go back, that is tissue excess, and we've got to remove it, and once we removed it, there's tissue loss. That's tissue loss. That's tissue loss, or failure to grow. That's tissue loss. That is tissue loss. An orbit after a young woman's had a malignant tumour removed from her eye, and she's got titanium plates in the eye socket, and she's got a great big hollow there which looks very disconcerting. She's 18 years old at that stage. Or this woman who's had the whole of her face, the facial skin, her facial muscles, her facial bones disappear, and probably that was due to damage to the from a viral cause to the trigeminal nerve when she was a little child, and you need sensory and motor input to get things to grow normally, and the theory is that that's why she ended up with such a strange asymmetry affecting everything. Or after somebody's had a cancer removed, you can see the lower lip's been removed, the lower jaw's been removed, the chin has been removed. Or this is the result of surgery when the child is a little baby. A cystic hygroma was removed in this person, so she's lost tissue. Or you've got a patient with developmental deformities like Treacher-Collins syndrome or Mebius syndrome, where the facial nerve isn't working, or this case, except we're not going to operate on this case, because this is a person who thinks she needs reconstruction, but when you look at her, does she need reconstruction? No, she doesn't. So we have to bear in mind the psychological elements of it too, that it's not just trying to replace lost tissue, it's also trying to improve people's emotional state. We don't have to say the Hippocratic Oath anymore, which is above all do no harm, but it is something to bear in mind. The last time there was a doctor's strike in Europe, it wasn't in southern Europe, it was in Belgium. What do you think, it was in the 1960s, what do you think happened to the mortality rate when the doctors went on strike for a few weeks? Somebody said increased? Hands up the increases. Hands up the increases. 1, 2, 3, 4, 5, 6, 7, 7. Okay, hands up to stay the same. 1. Hands up the decreases. Yes! The decreases win, you're right, absolutely. Because if you go through the surgical sieve, you've got congenital and acquired, and under acquired you can have neoplastic, traumatic, infective, and you go down the list, endocrine, metabolic, neurological, you go right down, and at the bottom you have iatrogenic. That's caused by us. So you take one medicine, you're bound to get a side effect, which means you have to have another medicine. You take too much ibuprofen or Nurofen, you get a stomach ulcer, you have to take ranitidine or lansoprazole. You know, everything goes. Then when you take that, you have another problem. So you have to have another thing. So we have all sorts of problems. And the key is that we want to cause the least amount of harm to a patient. So the ideal reconstruction is no reconstruction at all. We want to choose the simplest option. We want to reduce donor site morbidity. And the important thing is, right down at the bottom, ensure the surgeon and patient are agreed on the aims of the operation. You're not necessarily doing a life-saving operation if you reconstruct somebody. What you're doing is you're improving their quality of life. And if they have an unrealistic expectation of what you can deliver, then the problem is you're going to have an unhappy patient at the end of it. So it's very important that you explain to the patient what you can do and what you can't do. And don't try and pull the wool over their eyes and try and convince them you can do more than you can do. Also ensure the patient is aware of the risks. I've told you about trauma. You've seen slides of it, deformity and neoplasia. These lists at the top, that's easy. But when we get down to the bottom, that's very hard. We don't succeed with that. Cover and seal we can achieve. So particularly in this area, we want to seal, for instance, the brain off from the nose. If we've taken out a tumour that straddles the brain and the nose, if we leave a bloody great big hole there, snot gets up into the brain and you have snotitis in the brain, or meningitis if you want to give it a proper name, or encephalitis. So it's not a healthy situation. Contour and filling we can do pretty well. Colour, well, you know, look at the face. I'm a bit flushed in my cheeks now because I'm a bit hot. I'm a bit paler up here. I've got thick skin here, thin skin there. I've got hairy skin here. I've got a few hairs growing on my nose now. Those are very irritating. You'll get them someday when you get older. So, you know, it's colour, texture. We're not very good at that. You know, if I take skin from the back, it's a completely different texture to the face. And it's monotonous as opposed to the face, which is very, very complex in its texture. Movement. If I cut a facial nerve and I immediately repair it, I never get full facial movement back again, despite the fact that I've repaired the nerve. So imagine if we cut the nerve and we put a nerve graft in, and we put muscles in that aren't facial muscles because we've taken those out, we're really not going to get perfect facial movement afterwards. And then the eye, can we restore the globe of the eye? No, we can do prostheses, we can get them to move a little bit if the muscles are still there, but we have difficulty. So up at the top we can achieve, down we can't. Bone and cartilage, easy. Skin and fat, easily. Nerves and muscle units, I've told you that we can use them, but they don't work quite as well. And lymphatics are hopeless. Those poor women who have axillary clearances for breast cancer, and they get lymphedema of the arm because the lymph drainage is disturbed, it's almost impossible to get rid of that. A real problem. What are the materials? Now, I'm going to concentrate on autogenous materials. Autogenous mean from oneself. Homogeneous, from the same animal. So that's a face transplant. Xenografts from another animal, we've really stopped doing that, but we used to use porcine dermis to reconstruct thin orbital floor defects, so pig dermis. We used to do bovine cartilage, cow cartilage to reconstruct other things. And we also use bone, and people are still using bone harvested from cows to fill in defects. Small defects. Alloplastic means foreign materials like acrylic, like titanium, that kind of stuff. But I'm going to concentrate on autogenous because that's the main interest for me. So I like to break it down, and nobody else does this classification, but I think it's a very good classification. Vascular recipients. These are tissues that you take from elsewhere in the body that you lay into the area that you want to have them in, and they must gain a blood supply from the surrounding tissue rapidly, a random pattern blood supply. So if I take a very thin skin graft from the leg and I lay it on the face, first of all it'll look horrible, but if I lay it on the face, if it gets a blood clot underneath it that raises it off the deep surface, it will die because the capillaries can't grow into it. It has to have capillaries grow into it in the first 3 or 4 or 5 days. And if it doesn't get that, it will just shrivel and die. So those are grafts. Similarly with a bone graft, if I take a lump of bone from the hip and put it in the, or the pelvis, shall I say, not the hip, and put it in the jaw, if it doesn't have the soft tissues around with a good blood supply, in other words, if the tissues around have had radiation, so they've already got a poor blood supply, that bone will die. Or if those tissues are held away by blood clot, the bone will die. The tissues have to stick down onto it, and blood vessels have to grow in, random pattern blood vessels. And then you have random pattern flaps, I've mentioned that. And then we've got advancement flaps. So, you know, if you cut out a little triangle on the scalp, you turn around a lot of scalp to do that. And a transposition flap is moving it like that around, not turning around in a circle. And rotation. Here's an example of a bone graft. Here's a guy who was Turkish. At the age of 9, he stole a little moped and crashed into a wall, and he was brought over to the UK and had reconstruction of his face, but they forgot to put the eye back in the right place. So he had bits and pieces put in. You can see those bits and pieces, but they didn't put the cheekbone back in the right place, and they didn't put the eye socket back in the right place, and so that's how he looked. And so I filled up his eye socket with bone graft, but I could only go just so far because his pupil started to dilate when he was asleep, which is a sign that I was putting a lot of pressure on the optic nerve, so I had to stop at this point, and I only got his eye halfway up, but I got his eye further out, so that's him, with a bone graft in place. And then we've got, I've mentioned about axial flaps, and these are vascular donor flaps. So what happens there is they have a single vessel. Remember we talked about Bachangian and the delta pectoral flap. We talked about McGregor and the forehead flap on the superficial temporal artery, and the groin flap. Those have a single blood vessel bringing blood into the area. So they actually bring blood into the area, and they don't need any blood supply from the area that they're going into. Obviously they need a bit, but they can go into irradiated tissue which is badly damaged, and they can still survive, and they can still heal the wounds. So local axial flaps, which can be skin alone, can be skin and muscle, because we know, for instance, with the pectoralis major flap or the latissimus dorsi flap, that the artery that runs under the pectoralis major and runs into the pectoralis major to supply that, sends branches through to the skin. So if you take the pectoralis major muscle or the latissimus dorsi muscle, it will carry the overlying skin. So you can get skin from that area. And then we've got free microvascular, which is where we cut the blood vessels and reunite them. These are some of the lists of, we've talked about the glabellar flap for nasal reconstruction, and you'll see on your handout the blood vessels that supply them. So this is the guy who's going to come along, and you can just about see the scar on his forehead. There's a little inverted V just above his right eyebrow, and there's a straight line running up into his forehead. And if you look at the end of his nose, it's a slightly different coloured skin than the rest. He had his nose bitten off by a dog, and that's his reconstruction. So he doesn't look too bad. What happens is you leave it there as a sausage. It looks a bit strange while it's there as a sausage, but then after about 3 weeks you can divide it and change it around. Myocutaneous, these are some of the myocutaneous flaps. Here is a platysma flap. What we've done here is we've taken skin out from here. We've taken the skin off it because we want to bury it up there. She had a hollow up on her face there, and so what we did was we took dermis based on the platysma flap. Now the platysma is this muscle. Okay? If you do that, you can see that muscle there. That's the platysma muscle. It's the muscle lying just underneath the skin. And it is one of the panniculus carnosus muscles. Do you know what panniculus carnosus stands for? Horseflesh. So you see that horses, when they have a horsefly land on them, their skin wobbles because their muscle goes from skin to skin. What do muscles normally do? They go from bone to bone. So this is where it goes from skin to skin. And it's supplied by the facial artery. So we turn it up. There's a horizontal incision right up at the top there. So we turn it up through 180 degrees, and it fills out the cheek so that she doesn't have a hollow in her cheek. For some reason, she had damage to her cheek, and she lost all the muscle. She lost all the masseter muscle, and she had a great big hollow in her cheek, and that filled that in. There is another panniculus carnosus muscle, which is only in men, which is the cremaster muscle in the scrotal sac, and that's why when we're out in the cold, suddenly we all shrivel up, and our testes go up into our body because it's so freezing cold, to keep them warm for a better time. Autogenous microvascular, and we're going to go through some of these. Radial forearm, I'm not going to spend time on that because we're going to look at pictures. You've got it on your handout. These are, just to say, these are the sources of recipient arteries in the head and neck, so that when we want to join up the vessels that we've cut, we don't want to join them up to the superficial temporal ideally. The external carotid is brilliant. The facial artery is sometimes atheromatous because it goes through all sorts of turns, and also we're dealing with an aging population with cancer very often. The lingual artery is not bad. The occipital can be good. The transverse cervical can be used right down to the bottom of the neck when things are difficult. Recipient veins, what we can use. The problem with the hypoglossal is it's thin-walled and it tears very easily. Sometimes we have to do vein grafts and arteriovenous shunts. So what we want to do in these cases is we want to select patients carefully, particularly if we're not dealing with cancer. But if we are dealing with cancer, the worst thing we can do is have surgical hubris, which is we think we want to do the most sophisticated reconstruction on a 95-year-old woman who's got diabetes, hypertension, and is obese and has only got a year to live. Why are we doing such a big operation on them? What we want to do is get them in and out of hospital as quickly as possible. So we have to tailor the reconstruction to the patient. We may need to do an alcohol detoxification program. I've had patients die of detox, getting the delirium tremens. They've ripped off their clothes one day after the operation, after a 12-hour operation, and they've been storming down Whitechapel High Street stark bollock naked, having ripped out all their drips, pulled out their catheter. That must have been very painful. And with the thing still, with the balloon still inflated. With the balloon not inflated, it wouldn't have been too bad. But anyway, all the men in the room are starting to cringe, I can see. We've got longer urethras. So ensure no compression, all sorts of things to do. I'm not going to monitoring. This is for the postgraduates, really, and examples in action. If you've got a non-microvascular flap, if you've got a pedicle flap and it's going blue, that means the vein is not draining efficiently, the artery is draining. And what you want to do is take it away, because you've usually turned it through 180 degrees, take it back and put it back in its original place for a couple of days, let it settle, and then put it back again, it'll be fine. If you've got a microvascular flap doing that, get straight back to theatre. So I've spent most of today working with Professor McCall from Bradford, who is the new clinical research lead working with the National Facial and Oral Research Centre. He did a major case yesterday, which finished at about 7 o'clock at night. Unfortunately, the patient was on high dose of heparin because the patient had a pulmonary embolus before the operation, and the patient bled during the night, and so he went back to theatre to take away the hematoma and to untwist the vein. So he carried on working till 4:30 in the morning, went home and caught the train at 6 o'clock so he could be with me at 9:30 in the morning to discuss things, and he stayed awake all the time. But the point is, immediate return to theatre if there's a problem. So here are some composite problems. We're going to look at some pretty pictures now, and I like to use subscapular system flaps for that, based on the subscapular artery which comes off the axillary artery, and it splits into multiple branches. This is the latissimus dorsi, that's the scapular bone, that's the serratus anterior going to rib. So you could take multiple flaps, as you'll see. That's it drawn on the patient. That's the position on the table. Here is the situation where we've taken rib on the serratus anterior, latissimus dorsi muscle and skin, and scapula. And we're using that to reconstruct a complex defect of the upper face and the skull and seal the brain. So the great advantage of that is that you can take quite complex things. We do combined neurosurgery cases where we have to remove things like this. This poor guy had the unfortunate name of Hakim Shitter. He was a very famous photojournalist in Nigeria, and these are two malignant recurrences of sarcomas that he got. You could see he's already had one operation where they've removed his right ear in Nigeria, and where they've removed a lot of scalp. They've left him with facial nerve palsy, so he can't frown on the right-hand side. When he came to the operating theatre, he could barely hold his head up because he was... Has anybody seen Hitchhiker's Guide to the Galaxy? Okay, so Zaphod Beezelbrock had 2 heads. This guy had 3 heads. See, one in the middle, one at the back, and one there. And there's also a great film called Get Ahead in Advertising. Anybody seen that one? So the one head growing, so they'd obviously seen this guy and got the idea for it. So that's him afterwards with a simple reconstruction. He died about 18 months later. He refused any chemotherapy. He went home. Similar kind of flap to resurface the whole of the scalp, so we pulled up a bit of the scalp. You can see his hairline has gone up there. Can you see that? His hairline's down there, and all of a sudden it's above his ear. So we've pulled the scalp up, but also we've taken latissimus dorsi to cover the front. There's Henry Ekpe with his thing. So this was a guy who had he was an obstetrician gynecologist. He had a malignant tumour. I was away on holiday. He was operated on by my neurosurgeon with another surgeon, internationally renowned surgeon, but he didn't bother sealing the nose from the brain. And this guy had pus, and you could see the hole between the skull and the nose there. We're looking in the skull here, and that's the hole at the top of the nose that was left there. And so he had snotitis. My neurosurgeon persuaded me to operate on him, and I thought he was doubly incontinent. He was an obstetrician and gynecologist. He had 2 young children. He was doubly incontinent. He was gaga, and I said, "What's the point? He's dying. He's got recurrent cancer or something." He said, "No, let's give him a try." So he woke up immediately after the operation when we cleared all the pus and rubbish out of his head, which was on his frontal lobe. That thing on the side of his nose I removed later on. It was just a marker to show me that the flap was alive. And what we did was we put a titanium plate over where the bone was, which had gone rotten, and you could see he's bright and alert, and he woke up talking, and he wasn't doubly incontinent anymore. So this is a very famous actress who had her eye removed for melanoma, and you can see the eye socket there, what's left of it, and we've put in scapular bone and left her with a lump on her face, which he covered with a... So if you come to the Saving Faces offices, you'll see a painting of her with her daughter 6 weeks after the operation when she was performing in the Seagull at Chichester Festival Theatre. So what she did was she wore an eye patch over that area. Here's a guy who had the whole of his tongue removed and had his latissimus dorsi muscle put in. We didn't shave the hair off, unfortunately, but he's able to talk and swallow. He doesn't have a tracheostomy in. So you can replace the tongue with... and he married a young Latvian girl about 30 years younger than him. Again, this is a recurrent tumour after radiotherapy in a patient of a colleague of mine, and I did the reconstruction, and what we did was we took away the whole of the lower lip and did that, and took in bone and skin. Bone and skin again. Bone and skin again, taking away the whole of the mandible in this young woman, plus the skin out on the outside, plus the stuff on the inside, and that's her afterwards. And now on to some advances. This is a patient who's having the right side of the jaw removed, and we've planned exactly what we're going to do at operation. And there it is, we've got drill guides. You can see the things that we've put in, that we know exactly that we're putting it in the right place. And then we make us some teeth that fit on the same time with implants. Again, planning. This actually is, they're two different things. This actually is Doreen's model. Doreen's going to talk to you in a moment. Doreen had a recurrent tumour 30 years after her original tumour, very strange tumour. It was a salivary tumour which grew into her mandible. That isn't the shape of a mandible at the time. It was out here like that. But we trimmed it down so that we could bend the plate. And you can see that the arch that's created is much the same on both sides, but you've got Doreen here to talk about it. There's the implants put in the bone and the bridge made, so the patient woke up and the first thing he said was, my teeth don't meet properly. Not, I've got pain in my back, not anything else. And we not only reconstructed, taken away his tumour, half his jaw on the left, and also the and reconstructed him with shoulder blade and skin, but we also put in implants and teeth at the same time. Here's another guy who had his face shot off, and you can see he's had several other injuries. And so with the same technology, we can reconstruct him so he looks like this afterwards. So his wife is disappointed because she said, you were meant to make him look like this, and we didn't quite make him look like that. But he didn't look too bad. And this is the planning that we did for him. So that that's his first operation, and you can see he's got a composite flap again. He's got the latissimus dorsi muscle, which we used to reconstruct the lip in the first instance. And that is the bone and the skin for the outside and the bone for the inside. So we had a tripartite flap which achieved that. There he is, the flap is put in place, the muscle is carrying the blood supply to the bone. So we can't take the muscle off, which makes it a bit bulky, a bit more difficult. And the implant proformers are in there. This is the planning before the surgery by the dentist. And there is the bridge put in. This is his latissimus dorsi muscle, which is kind of squeezed between. Those are his broken teeth in the upper jaw. He had a good set of teeth beforehand, but those were shattered too. That's him immediately after the first operation, and you can see he's got a huge mass of latissimus dorsi, but because we've cut the nerve, it shrinks down, and so that's what it looks like after a few weeks, so it's shrunk down a lot. But then what we do is we do a carapandage flap, that's the implants in there. So what we did was we make cuts along here and along there, and we transpose the upper lip to the lower lip, take away this, so that he then, as you can see here, so the sharp-eyed amongst you will see that what we've done is we've turned it round, we've actually done a separate operation to do the Glasgow smile. So we've slit his thing. We don't use razors to do it, and we do stitch it up afterwards. In Glasgow, they don't do that. And then you can see where it's joined, where we've joined it. So that we've used, that's called a carapandage flap. Morbidity, after we've taken shoulder blades, this is a woman who's had the whole of her jaw reconstructed, the whole of her tongue reconstructed, and she's still talking 10 to the dozen. She was a teacher and she doesn't stop talking. But you see that even after having the shoulder blade removed, they can lift their arm right up. And this is a face transplant. And so the question is, on the left-hand side is my patient who had his, who shot his face off. He attempted suicide, shot his face off, and shot the central part of his face out. This is what this guy had, and that's how they reconstructed him in Spain. But all his problems are in the center. They didn't do a good glabella flap, they didn't do a good treatment here, so the central part of his face is dreadful. The cheeks are fine, the eyelids are fine, the eyebrows are fine. It's only the central part of the face. So I haven't got a post-op photograph of him that I can find. I mean, it's buried in all my piles of photographs. This is the painting of him done by the Saving Faces artist, with him sitting there. He was blind afterwards, and his frontal lobe was changed, so he became, instead of being a stroppy guy who wanted to kill himself, he became a very gentle, sweet guy, and all his grandchildren loved to sit on his knee. Anyway, so that's him afterwards. We've reconstructed his upper jaw, his lower jaw we've reconstructed as well. We were able to find skin of the face that we could move around, and the only skin that we couldn't, so we did reverse facelifts, the only skin that we couldn't find was of the bridge of the nose, and so we did that. So, which looks better? That's a face transplant who's got to have immunosuppressant drugs for the rest of his life. Is that the way forward? You know, is it better than the thing that we've done? I'm not sure. So we've got reconstructive complications. Fortunately, death is not the commonest complication. Donor site morbidity is. We try and keep that to a minimum. And the future has to be not the things that I do, pinching body parts, but tissue engineering, which I think Professor De Silvio is going to tell you about now. So, without further ado, as I've talked for far too long, you've got as long as you want, Lucy.
Let me find it first. Maybe I need my other glasses.
Is that it there?
Well, it gives me great pleasure to be here this evening, even though Iain just told me about it late last night. So I pulled out what I could from one of my lecture series. But I did change the title because I thought about what it is that we're trying to do. And essentially we are, and he's demonstrated that quite beautifully this evening, we are actually minding the gap. We're constantly looking to fix, replace gaps. And I'm going to talk to you a little bit about some of the work that we're doing in our laboratory. First of all, I put this picture in because I thought you might like to see where I live. I'm actually based at Guy's Hospital. And we used to say to people, when you get to London Bridge, look for the dirtiest, ugliest building, and that's Guy's Hospital. Now we say, look for the tallest and nicest building, and we're the ones that we're next door. And I'm literally sort of overlooking, and I've watched this thing go from scratch to being what it is today. So what I really want to talk about is a concept. We have a concept, and the concept is, as Iain has indicated, that we want to try and replace a tissue. We want to try and replace a tissue in a natural way. So we have an idea of how we think we're going to do this. We need to speak together. We need to communicate, because you can only do this kind of from concept to patient by discussing the problems with the clinicians. And then we look at how big is that space that we have to fill? What kind of properties do we want that material to have? Do we want that material to be degradable, non-degradable? And then once we decide on the kind of material that we're going to use, and we do try and use, as near as we can, materials that mimic natural tissues in the body. And then we have to obviously evaluate it in vitro, because we can't go just from an idea and then sort of put it into patients. So my group, we call ourselves a translational research group, because we actually go right from the concept, and I can say that one of our materials that I'm going to talk to you about this evening is actually going into clinical trials, and I'm pretty proud of that achievement. I've put this up, and I'm certainly not going to talk about them all, but I just want to show you the scope of what we're doing. It's an enormous area. I have different people working on different things, and I don't work alone. We work as a group. number one is all about the different cell types. And you can see I've listed a whole load of different cells, although my work is predominantly with stem cells. But we do lots of other work, and we do some gingival work. We look at osteochondral defects. We look at cartilage cells as well. But it's about using these cells to create environmental niches. Environmental niches are the kind of environments that these cells live in the body. And we really do have to understand the mechanisms whereby these cells, because although in vitro we do lots of experiments using single cells, in the body, as you well know, they exist in unison with other cells. So we have to try and understand this crosstalk and how these cells communicate. And that takes us into number two, cellular models. We've spent a lot of time, and I've had a lot of PhD students working on developing models whereby we have different cell types in coexistence. For example, I want to make bone, but as we've had pointed out, how important vascularization is. So we need to have these cells working together and communicating together. And because the areas that we're trying to repair, regenerate are large, we can't do that without scaffolds. There are other biologists, scientists who would argue and say that we don't really need scaffolds at all. If you get the right kind of cells with the right kind of molecular signaling, these cells can just reconstitute a tissue. Well, I beg to disagree with that. That's fine if you're talking about a subcritical defect, but if it's a critical defect, there is no way that you can manage to occupy that space without having some kind of scaffold or template. And I've listed a few things here, but most of the materials we work with are porous scaffolds, things like hydroxyapatite, which is in your bone anyway. And a lot of these materials, surgeons would like, depending on the size of a defect, they would like either something they can shape into the right shape or something they can inject. And we're working on both of those criteria. And in our injectable cell-seeded scaffolds, that's sort of very fancy stuff where we're making hydrogel-type materials where you can mix the cells in with your materials and then inject them directly at the site. So in situ regeneration, if you like. But of course, we can't go from here into a clinical trial without going through the translational research via an in vivo model. And here I've listed a few, but we work, I must add, I'm not one of these scientists who will simply go into an in vivo model. I firmly believe that there is so much that we can learn in vitro before we even think about going in vivo model. And if you think about the in vivo models, even the ones that I'm going to show you, how much do they actually represent what's actually happening in nature? Very little, because if you think of the size of the animal, if you think of the loading of the different bones, they're not really representative of what's happening in the body. But we do obviously have to go through an in vivo step before we can go to clinical trials. Just a bit of background, which I'm sure you already know. There's an estimated 1.6 million bone grafts performed every year, and of those, 6% are craniofacial in nature. And Iain has talked about some of the methodologies that are used, some of the techniques, the therapies. Autologous bone is obviously ideal, but when you're talking about restructuring the sort of traumas that he's shown us, you would need an awful lot of autologous bone to do that. And obviously you can use allogenic bone as well, but even so, you would still need a tremendous amount. And in situations like the ones that Iain has shown us, we would have to turn to bone substitute materials. And these are some examples of some of the materials that we use. This is hydroxyapatite here, and this is, again, hydroxyapatite, but you can't see it very well, but that's actually got cells on it. But the crucial point in all of this, and again, Iain has said, and I will keep repeating it throughout the whole of my talk, is that if we're going to ensure any kind of success and long-term outcome, we simply have to have some form of vascularization. It's not enough to take these scaffolds, to place these scaffolds at a site and just hope that nature's going to do the rest, because it won't. If it's a critical size defect, you're asking an awful lot of that material and an awful lot of a compromised site where you've had trauma, you've got nerve damage, you've got vascular damage. You're expecting an awful lot of that site to repopulate a scaffold such as this. So there's been this paradigm shift to regeneration instead of transplantation or implants. But that's not new. Nature has had it for an awfully long time. I don't know, I was quite excited when I was talking to my niece who was doing her biology homework, and she was talking to me about regeneration of tissues, and she brought this out as an example, and she said to me, you know, Auntie, is that true that this can happen? So I said, well, yes, it can. I said, you can even chop a head off a newt and it will regenerate itself. But the thing that's unique about a newt is that it can, when you cut off a specific tissue, that cell, the cells in that particular tissue are already differentiated cells. So whatever bit you cut off, they will simply go back into their cell cycle and they'll just keep dividing and dividing and dividing. So if it's, whatever tissue it is, that tissue will regenerate itself, which is very different to human regeneration. These are human stem cell, mesenchymal stem cells. In contrast, these cells are actually locked out in a sense. Once these cells have differentiated, once stem cells have committed to become bone, cartilage, bone marrow, whatever, that's it. They're in a differentiated state. There's basically no going back. That's why using pluripotent stem cells is an extremely exciting option. And not just my group, but many groups are using these cells and driving these cells, because you've got to switch them on. Unless you tell them which way to go, they'll sit there in their non-committed state. And the challenge is getting these cells to switch them on and to become a specific tissue, specific cell to form a specific tissue. So how are we treating? What are the treatment modalities? Well, Iain's better equipped than I am at telling you this, but basically the majority of patients are treated with scaffolds alone, and these you can buy bio-os and various osses from various companies. But calcium phosphates tend to be the most commonly used. So that's in the majority of cases. In more severe cases, you might find that it's not enough just to put the scaffold in. You had a very compromised site. You might have to add a protein to stimulate or induce the cells within the site. And here we might combine it with an osteogenic protein, something like bone morphogenetic protein. This is used quite routinely. It's used in lumbar spine fusion and for reconstruction. When you have the most extreme cases where you really have a compromised site, where you really have poor cell quality, where you really have a compromised vascular situation, the ideal treatment, one would, if one could, would be cell transplantation, and this would be in combination with your scaffold and with your osteogenic factor. So, as you can see, some of these, certainly the trachea, Alex Afalian at UCL made him famous, and UCL famous. He managed to reconstruct a trachea, he actually did it with a synthetic material, and he allowed stem cells to grow on this and added various differentiating factors to get this into a collagen type trachea. So there are two basic approaches that you can use for tissue engineering. You can use the acellular. The acellular approach is where you just use the matrix alone, and basically you allow nature to do the rest. So the material will recruit cells by perhaps being functionalized with some surface modification, or cellular matrices where you would want to add cells to that as well, and you incorporate the cells with the signaling molecules. Because remember, if you just put the cells alone, the cells won't know which direction to go, so you do need to have these signaling molecules. And when we're thinking about utilizing stem cells for engineering, we really have to think about the hierarchical structure, because we're going from sort of a sub-nano structure right to a macro structure. So when we're in the lab and we're thinking of how we're going to switch these cells on, it's important for us to know that these cells, not only are they going to differentiate into osteogenic cells, but they need to be able to mineralize and form bone with exactly the same structure, hierarchical structure, as natural bone. And the success of any of these cell-based therapies has got to be in our how we're going to retain these cells. So we can take the cells from the bone marrow stem cells from the pelvis here, we can expand these in culture, but if we're going to put them back in a reconstructed jaw, for example, we need to have a way of retaining these cells. You can't just inject them and hope that they'll find the right place and stay there and start to make tissue. So these are the different materials that we work with. But predominantly, I'm going to talk to you about calcium phosphate. So when we're talking about designing these grafts, scaffolds, grafts, matrices, whatever you want to call them, we need to be very precise about what we're asking of that scaffold. And the most important thing is that the body has to be able to recognise it as self. So it's got to mimic natural tissues. The other thing is you've got to please people like Iain. It's got to be easy to manipulate. You can't have a material that in the theatre, you've got to mix it with A, B, C, D, add 2 drops of whatever. So it's got to be easily manipulated. And it's got to be manipulated in a way that you can achieve the same structural compatibility with the defect site. You can't have too much sort of chopping and carving and moving around. And most importantly, mechanical integrity. I had this discussion with my students this morning about if you're a material scientist, all you talk about is how strong a material has to be. If you're a biologist, all you talk about is how biological responsive that material's got to be. And one or other of us is going to have to give in a little, because you can't have both. You can't. It's very difficult to achieve a material that has has a very good mechanical integrity and a very good biological response. Usually you might have to compromise one for the other. I would favour the biological, because I think that if you have a biologically responsive material, you will initiate the regeneration of tissue much faster, and it will form its own mechanical integrity. But above all, vascularization. You can create the most amazing scaffold with cells and factors, but if it's not going to vascularize, if it's not going to integrate with the host tissue, it's going to be a failure. So one of the programs, one of our very big programs, this is an EPSRC welcome grant, where we've just had our midterm report, and I'm very pleased to say we've made the second half, and they've given us the other half of the money, otherwise they're going to take it all away. And basically, this project is, there are an awful lot of us. It involves St Thomas's, Guy's and King's. It's an 11.4 million project, of which my group got 1.2, so I'm very pleased about that. And it's looking at the fundamental concepts that underlie the biology, engineering and manufacture of tissues concerning the face. And what was the objective of my particular group was to try and develop this bone graft, and I say with a tissue-like assembly of endothelial cells and MSCs, to actually achieve some sort of primitive vascularization ex vivo, to then to be able to transplant that back into a patient. So the material is a beta calcium phosphate, metaphosphate. Loads of people work with calcium phosphates. There's nothing fancy about the material, except we have played around a little bit with its manufacture to try and achieve the right kind of porosity. Porosity is really important because you have all sorts of materials that you use in the body: dense materials, porous materials, microporous, and this material has a mixture of different pores, and you need different pores for different reasons. The microporosity is important for diffusion of gases and nutrients. The larger pores, the meso and the macro, are important because you need to get different cells to be able to infiltrate that scaffold. If you have a very large defect and you're only getting infiltration of cells on the outer edges, the inner core is not going to have cells in it, and essentially the cells, or the cells that do reach that area, can't communicate because they're not getting the right gas, the right nutrition, and these cells are going to die, produce toxins that are going to kill the other cells around. So essentially the implant's going to, or the graft is going to fail. So, and the neovascularization is very much dependent on the rate and the rate of remodeling, because the other thing that's important is that you've got, if you're in tissue engineering, ideally you want that scaffold to go away, to resorb with time. But what is important is that you have the rate of neo-tissue formation has got to be equal to the rate of degradability, because if it isn't, you're basically going to end up with a hole again. And that's limited. Obviously, the diffusion of oxygen is very important as well. So, you know, in order to have this uptake of oxygen and removal of waste, we've got to get the right kind of porosity, the right kind of structure. And it's not enough just to have holes. Those holes have to communicate, because you can have pores, but you can hit a brick wall at the end of a pore. So the challenge in getting the right kind of scaffold is to have the right kind of porosity, but the right kind of interconnectivity as well. So, although neovascularization is generally derived from the recipient, so you know, you're putting your graft and you're hoping that you're going to get some of the vasculature from the recipient, there is no doubt that there is a cellular contribution, because we've shown this in vitro, and we've shown that where we've added cells just to the surface and the cells haven't been able to get inside, and we've done sections of these, you can see the area of necrosis as you get further and further in the graft. So how can we achieve this vascularization? This is in vitro. So obviously we had to do this in vitro before we could go into our in vivo model. So we needed an appropriate scaffold, appropriate design, appropriate porosity. We needed these factors that are going to switch on these cells, are going to coax these cells, because remember, these cells don't know what they're going to become just yet. And we worked with a variety of different cells. So MSCs are mesenchymal stem cells, HOBs are human osteoblasts, so they're committed cells, they're bone cells, and HUVECs are human umbilical vein endothelial cells, basically. And I don't know how well you can see this, but if you take these endothelial cells and you put them in the right 3D environment, whether it's collagen or fibrin or any kind of environment, you will get these sort of tubular-like structures. They will form irrespective. As long as they've got this 3D structure, they'll just form. And people write in papers, and I've reviewed papers where they say, I've got angiogenesis. Well, it's a load of rubbish. It's basically these cells that are forming these kind of aligning in a tubular-like structure. What you do need to do in order to mature that into a vessel is that you need to have other cells. As I've said, when we do various studies in vitro, we're usually using one cell type and we ascribe that response all to that cell, but it's not. It's all about these cells talking together. And certainly to mature those vessels, to mature that capillary-like structure into a vessel, you need to have all of these cells in unison together so that they talk to each other and produce the right kind of stimulatory factors. So in this cartoon, I'm depicting basically almost 3 years of my PhD student's thesis. He took these human bone marrow stem cells, and he used two approaches. He took a mature osteoblast, and he took stem cells, and we tried to see which of the two achieved a better mineralization in synchronization with angiogenesis. So human bone marrow stem cells, osteoblasts, and we put these together in a co-culture with HUVEX. How we needed the BMPs to switch to drive these cells down the osteogenic route and mineralize and become bone, and we needed the vascular endothelial growth factor to switch on these endothelial cells to form these capillary-like tubal structures in order to get this pre-vascularized CMP as the calcium metaphosphate scaffold. So putting this all together, we can see that having this bioactive scaffold, it's become bioactive because we've put these various factors in it. We can seed these various different cell types together. They can coexist and they can basically form, we've shown that we can form bone and with these structures, tubular-like structures. And I'm going to prove that to you with some images. This is just on a 3D collagen to show you how you get this sort of tuber alignment and tuber formation. But what is the important bit is in the actual scaffold itself, because that's the proof of the cake, is that this is our scaffold. We're now in the middle. So we've cut this scaffold. We are now in the middle of that scaffold. And you can see this lovely tuber-like formation inside the scaffold. And it's all very well, but you know, you can turn around and say to me, that could be any cell aligning making that tube. How do you know it's an endothelial cell? How do you know it's a vessel-type cell? Well, we've stained it with all sorts of phenotypic markers. CD31 is a marker for endothelial cells. And this little brown, all these brown dots that you can see here is staining positive for CD31, indicating that those endothelial cells are of the right nature and type. This is we've got with the Wellcome Trust money, we were able to buy, well, not buy, we've actually, one of my colleagues has built it, a 2-photon confocal microscope. This has the most amazing power that you can actually go inside the scaffold and actually image what's going on inside. And unfortunately, my movie doesn't work, but I've got a lovely movie where this is a still, but this is a movie where you can see as the probe is going inside the scaffold, you can see how this lovely network is throughout the whole scaffold, just not on the surface. And here again, this is CD31, and all the fluorescent stains here are showing you there are a lot of those cells that are positive. And von Willebrand, again, is another marker of endothelial cells, so that we're absolutely sure that these cells and these tube-like structures are endothelial aligned cells. Is that going to work? Probably not. No, it's not. Anyway, again, all this is simply showing that we're able to look at all these different proteins that these cells would normally express in the body. So we want to be assured that inside that scaffold, they're behaving exactly the same way. So we're looking at different proteins here. This is vimentin, and that's a very important a filament protein, intermediate filament proteins. And here, again, we're inside now, inside the tubular formations, inside the scaffold. And you can see it here, even on light microscopy, you can see it. So I've only showed you a little bit, because obviously it's a 3-year PhD. I can't possibly show you all his work. But having satisfied ourselves that we could achieve that in vitro, we then, and having confirmed that we can get these cells to be switched on to become endothelial-like or bone-like, we decided to move on to an in vivo model. And this model was a rabbit model. This work was done in Sweden with Lars Seneby. And basically it was a 5 millimeter wide and 3 millimeters deep bilateral defect. And we've done this in 2 phases. This is phase 1. Phase 1, we were asking the question, because one of the questions I often get asked by clinicians is, you know, people talk about scaffolds needing BMPs and scaffolds needing cells, and do you need both, and which do you need? So we decided to do a systematic study. In this study, we looked at the scaffold on its own and the scaffold just with the protein. And in the second study that we're starting in March, we're going to look at incorporating cells. So why did we choose these time points? We chose 2, 4 and 8 weeks. And the reason we chose those were that at 3 weeks, we were hoping to see at least that there was no inflammation and that the healing process was going on. At 4 weeks, we were very confident that we were going to see some new bone formation and some neovascularization. And at 8 weeks, we were hoping to see that the scaffold would have completely been resorbed and we'd have complete new bone formation. So we went back in after 2 weeks. Basically, this is our sample. At 2 weeks, we did have a bit of inflammation, but it was very short-lived. We had good soft tissue healing, and we began to see that the graft, you can't see it very well from there, the graft had begun at 2 weeks already to be resorbed, which we were a little bit surprised because it was a little bit faster than we had anticipated, because certainly for a clinical trial, that would be pretty fast at 2 weeks. You can see it better here maybe. These little dark grey bits are the actual scaffold. But as you can see, it's being infiltrated by bone that's being formed. So a bit fast, but needs to go back to drawing board for slowing it down a little for an in vivo study. At 4 weeks, we can see the mineralized bone again, and this is lined by, we see osteoblasts lining the osteoid seams there, and the whole area seemed to be taking on a more bone-like appearance. By 8 weeks, the beauty of it that we had almost no scaffold left at all. It had completely been resorbed. And when we compared the scaffold alone and the scaffold with BMP7, we saw significant enhancement in the bone formation in the presence of BMP7. And we did some lovely or rather BB did for his PhD, some lovely reconstructions of the actual defect, and you can see that we got this beautiful healing and beautiful reconstruction. So we looked at total bone induced, and what we found that we measured various parameters. So this is bone volume over total volume, and we found that in the presence of OP1, we had the greatest bone volume with stimulation of that protein. So that was one. So the first in vivo study basically demonstrated that we can enhance the rate at which that bone is formed by inclusion of the bone morphogenetic proteins. So now we've just got another tranche of money from Orthopaedic Research UK, and we're about to embark on this now in March. And the purpose of this second study is to actually ask, well, what is the ideal graft? Is it one that's pre-vascularized in vitro? Is it one that has the BMP with the stem cells? Is it one that has just the stem cells alone? And we hope that by the end of that study, we'll be able to categorically say, with this particular scaffold, you don't really need to have cells, it's enough to have the BMPs, or depending on the site, you may need to have the BMPs and the cells as well. But the biggest challenge of all will be if we can get this pre-vascularized scaffold ex vivo and transplant it back and see whether you get anastomosis. Following that, we're already putting in application for clinical trials. We've decided that because it's sort of fairly new, we didn't want to go into a highly compromised site. We thought we'd play it safe in the first instance. So we're basically going to go for a gap. We're going to, normally bone is removed from one site and used in another for reconstruction. In this case, it's from the radius to reconstruct the face. We're going to use our scaffold at the site where the bone is removed. So it's a little bit more controlled. We thought it was a little bit too adventurous to go straight into a large trauma site. And so we're hoping that that will start in approximately a year's time. So I guess what I really want to conclude is that vascularization still remains a challenge, and it's got to be overcome if we're going to use this kind of approach for clinical application. But we propose that it can be done, and this new strategy is to fabricate these vascularized graft. But the important thing is that you use a biomimetic scaffold that the body recognizes itself, and we do need to incorporate these signaling cues because you need to switch on these cells and become committed down a specific lineage. And I think that's all I want to say, and I'm happy to take any questions.
Well, don't go.
All right.
Okay. I think you're incredibly fortunate to have heard Lucy speak tonight. This is the future. This is the exciting things, and you heard somebody convey it. Certainly, I understood it, but I had lots and lots of questions afterwards. But I think I'd have to watch the lecture again and take notes so that I could ask you questions, because I've forgotten. There were so many questions I wanted to ask. I can't remember. So what you've got here is a taster.
Certainly that.
And what you need to do is every time you see a lecture with Lucy De Silvio on, you have to go there and make sure you hear her so you see the advances that she's doing.
I pay him to say that.
Anyway, I thought that was brilliant, Lucy. Thank you so much for coming at short notice. What we'll do is we'll save the questions till afterwards, and we'll get Doreen to come up. Doreen, would you like to take a seat here? Are you happy with these seats here, or do you want them? So Doreen, do you want to fire away?
Right, well my story started when I was in my mid-20s. I went to my dentist, no particular problems other than irritation with a wisdom tooth, or so I thought. The dentist took one look at my mouth and said, "Oh, I can't do anything. You've got to go straight to Barts Hospital." And I said, "Why? Is there a problem?" He said, "Well, you've got a blocked gland." So off I went to the emergency department. I was seen fairly quickly, and they said that they wanted to do a biopsy because I had a lump on the gland, which they did that, and I got a call on probably a day or two asking me to come back. They said they wanted to remove what they thought was a cyst. Well, that was then 30 odd years ago. I didn't have MRI scans or things like that, so within a matter of weeks I went in, had the cyst removed. They did tell me, however, that it could grow again, but there wasn't really anything to worry about. It wasn't cancerous or so they thought. So I went back for checks. Well, I had a few stitches. It was a little bit sore. Had a week off work. Went back, I think twice. They said everything was fine, and that was it. Over the years, I'd had quite a lot of dental treatment. I'd had caps and on a couple of occasions, so I was regularly went to the dentist, always went for my 6-month checkups. Then it was probably about 20 years later that I started having problems with my lower teeth, and they started to no, I've missed a bit actually. I've got a lump under here, and I thought, oh, it's probably because the glands, he did say that it probably would drop a bit and that it would never be as it was before. This is when he did the operation. But gradually it got bigger and bigger, and I had quite a stressful job, and you know how you do, oh, I'll go to the doctors tomorrow or the next week, or I can't do it this week because I've got this, and then my bottom teeth started to fall out. So then I realised, hey, I've got a bit of a problem. So I went to my dentist, who I knew very well. In fact, in actual fact, he was a neighbour of ours, wasn't he? And I said to him, look, Miss Peters, I'm really concerned now. So he said, well, I'll take a few x-rays, which he did. And he said, well, everything seems okay. So I said, well, I don't think it is okay. Why? You know, what, your teeth just don't fall out. Then, because I was so insistent, he made an appointment for me to go to the hospital. In between all this, letters got lost and, you know, what admin can be like. Then I eventually did see, I call him Max Factor, but it's
That's right, yeah, Max Factor, isn't it?
Whatever you want.
yeah, Max Factor. And he did some x-rays, came out, went back in, did some more. Then he was a bit shell-shocked.
He was shell-shocked.
And said, I've never ever seen anything like this. He said, I know you've come here about this lump in your tooth coming out. He said, but he did the x-rays and there was...
No, he sent me for the CT scan, didn't he? To get a CT scan on it after he's done the x-rays.
Oh yeah, after the x-rays he sent me for a
CT scan.
CT scan, and it showed a tumour that had travelled over the years.
It showed like a jawbone, didn't it? And
Yeah.
there's all black holes in it.
Black holes
way
in it,
round
it had
the
travelled
yeah.
completely round the jaw, from one end to the other. And he said, quite honestly, I've never seen anything like this ever before. So he referred me to a professor who I went to see, who I actually didn't end up, I think I've got 2 or 3 different opinions. And then I stumbled across Iain Hutchison.
I was lying in the road drunk at the time.
No, actually, I've missed a bit there because when I went to see the professor, he said he didn't actually know at this point what they could do because he'd never seen it either. So they were going to hold a...
He said they could do different things. He said they could either... One idea was to, at the jawbone, was to scrape tumour out of it. Something like
or
that.
try to...
Try and scrape it all out, clean it out that way, instead of operating on it, like sort of. But then he said he couldn't guarantee that he'd get all the tumour out of it, like sort of thing. So the other operation would be to have the jawbone. Like
no, but he didn't
but
know
then-
that at the
no,
time.
but
He
that's what
said
was
that he
saying.
would have to get a group of consultants together and have a meeting and see what they came up with. I think you was invited to that meeting, Iain, but you couldn't have gone because you was doing something else at the time. So it was quite worrying. And then I met Iain Hutchison, who, when I went to him, he kind of knew what he had to do, I think. And I'll let you...
Yeah, but you've got confidence in him as well. didn't you?
Yeah, I did have a lot of confidence in him.
Highly unusual. No, you see, I'm not that humble a surgeon, really. I always know what I have to do. Whether it's right or not is another matter, but anyway. So I felt that it was interesting that that I was a consultant with Barts, but we couldn't get hold of her original tissue, and we couldn't get hold of her notes. But eventually we got hold of them that showed that it was a pleomorphic adenoma of the parotid gland, of the sublingual gland, and in fact what had happened was that the pleomorphic adenoma, highly unusually, had grown into the bone and had infiltrated the bone and created a great big swelling of the bone from angle to angle. And so the only way to get it out was to take it out completely and to reconstruct it, which is what we did. to tell about the complications you had afterwards?
Yeah, you did, didn't you? A few, didn't you?
Yeah, I think
You had a tracheostomy in.
That's right.
Do
Yeah.
you want to tell about
Oh,
the
yeah,
tracheostomy? and the
yeah,
problem?
I had a mucus block.
Yeah.
And
At the carina, that's the junction between the two lobes. So she had a great big mucus plug, and it blocked her. And I was there at the time,
Yeah, just lucky, yeah.
and she just couldn't breathe. You know, but fortunately she coughed it out,
Yeah,
or
right, yeah.
we sucked it out. A combination of sucking it out and coughing it out. But otherwise, she was going to die in front of my eyes.
yeah, it was that was quite scary because at the time the physiotherapist was trying to get me out of bed and said I had to walk. So I was trying to let them know that I couldn't breathe, but everyone told me to stop panicking. And I thought, hey, stop panicking, I can't breathe. But fortunately, Iain was coming along the corridor and my daughter went running along and she bumped into him and dragged him into the wall. And he quickly removed the tube.
Often the tube itself blocks, so the tracheostomy tube can block. What happens is that we moisten the air that we breathe and warm it. If we put a tracheostomy in and bypass the area, we're not warming and moistening the air we breathe, and so what happens is the trachea gets very irritated and produce a lot of mucus, and that mucus can, if you don't take out the tube regularly, the inner tube of the tracheostomy, and clean it, it can get blocked. So one of the reasons that people have difficulty breathing is the actual tracheostomy tube is blocked, and when you take it out, so those got a hole in their neck, they can immediately breathe normally. But that wasn't the case. She still couldn't breathe normally, so we had to get a suction thing and go right down to the carina and pull out this clot. But fortunately, you got enough air beyond it to then cough and expel it. So a combination of suction and coughing did the trick. I'm a very lucky man. I seem to turn up at the right time.
Well, I think I was lucky on that occasion.
I don't spend my whole time on the ward, but there have been several occasions where I've been serendipitously in the right place. Anyway, do you want to tell about the other problem?
Yeah, tell them about the
later on?
toe.
And then
we took fibula. Now, 3 blood vessels that run below the knee to supply the lower leg. If you take the fibula, you have to take one of the vessels away. Now, people who smoke a lot can get atherosclerosis and they have narrowing of the vessels, and so you may only have 2 vessels functioning properly. And if you take one of those vessels away, they'll end up with a below-knee amputation. And one of my predecessors here actually did a beautiful reconstruction of somebody's jaw with a fibula, but they had to have a below or above-knee amputation. So you have to check on that. So I talked about donor site morbidity. Above all, do no harm. So I'm very cautious about that. But anyway, you had the fibula taken. Do you want to tell us what the problem?
I did have quite a lot of problems with my leg, and it wasn't healing as well as I had hoped. But then I'd been at home probably about 4 or 5 weeks, and I noticed that my big toe and on the first 2 toes it started to turn under, so I couldn't walk. And every time I saw Iain, he was telling me all about this. All I kept on about, driving him nuts, was about my leg. And then he did get to look at it, and I think he was a bit shocked. Probably thought, I wish I'd have listened to her sooner. But
now that's an important point. We're programmed like computers to listen to the patient's symptoms and come up with a diagnosis. And the problem is, if the patient says something that doesn't seem to match, we get confused. And instead of saying, well, you know, all patients are different, or I don't have all the knowledge I should have, we start blaming the patient, and we start saying to the patient, clearly, you know, they're just making this up. And so, but the patient almost always, I can hardly think of any patient who's ever not told me the truth about what is happening to them. The problem has been that I haven't believed it because it's not been in my experience. So there's a lesson for you. Always believe the patient. They're always right. They're not the customer, they're the patient. The patient is always right. Anyway,
Well, so I then went on to have another operation on
she went
my.
to the best foot surgeon in London, Williams, isn't it? What's his first name? Wasn't it Williams?
Is it William?
Rothman, was it?
Anyway,
I've
you
got
went
his
to a very
name at
good-
home.
You went to a very good foot surgeon.
Top surgeon. And he, but he came in with the anaesthetist, and the anaesthetist said, "Oh no, no, no," he said, "I can't give you anaesthetic. I can't put a tube down your throat." So I looked at him, and I looked at Professor Rothman. No, that was the heart doctor.
Yeah, Rothman's the heart guy.
Right. I went to him as well. His name will come to me in a minute. So he looked at me, and we all looked at one another, and I went, "Oh, what happens now?" So I think they went out the room, come back in again, and said, "Well, there is a way we could do it if you're willing to do this," and that was to have the
Spinal.
the injection in the spine, yeah. What?
Epidural.
Epidural, yeah. So, we did that, and luckily, it was successful. The toe will never be as it was, and I think you learn to not expect things to ever be as they were, but it was better than trying to, not being able to walk on your foot. So I do lots of walking now, and I'm still very active. And
you've got the other thing.
Do you want to talk
About
about
your
the
throat.
tracheostomy?
Yeah.
oh yeah, and then when I
Couldn't breathe. Very good.
I used to have problems with breathing, and I got out of breath very quickly. And I mentioned it to Iain when I went on my checkups. And then one day, I think I met him as I got to the top of the stairs in Barts. And he saw me struggling for breath. And he said, "How long have you been like that for?" I said, "Well, for quite a while. I told you last time."
But you weren't listening, mate.
But you weren't No, I didn't say that. But
But you thought it.
and then he sent me for a CT scan, and again I went to another one of Iain's recommended surgeons, Mr. Goofer.
Yeah. He bored out your trachea. What had happened was that some of the soft tissue, we create a hole in the trachea, and some of the soft tissue got sucked inside. And we could have done an operation from the outside and just cut it out and and left it there. But he went down and just lasered it away to get it freed up. Now, so what you've heard there is then you had Andrew.
When he was lasering it, it went through a pipe, didn't it? Through a windpipe.
Yeah.
So that when she was breathing in, it was just blowing her out, wasn't it? Like,
Yeah.
When I took her out of the hospital, just got her outside the hospital, they give her the all clear, she could go home this day. She collapsed. I had to take her straight back in again. Took her to you, didn't they?
And then a few weeks later, they operated again, and that was okay. So there was a few.
And then you've also had the implants put in.
Oh yeah.
Yeah. Andrew made the titanium
Yeah.
plate prior to you operating.
Yeah.
And that was all going.
Exactly the form that her jaw should be. Yeah.
And that was all going well. And then I went back for one of my checkups, and Iain then said, well, it wasn't my idea, but they want you to have radiotherapy. So I had 6.5 weeks of daily radiotherapy with my leg plastered from there to there where I'd had the operation on the toe, staggering up to Harley Street every day on crutches to have radiotherapy. Then Andrew was quite concerned, Andrew Dorburn, the dentist, who was worried then that all this work that he'd done, that perhaps I couldn't have the implants after all because of the radiotherapy. But luckily he persevered, he done wonderful work, and hence I've got the implants.
What
Still,
type of diet do you eat?
pardon?
What type of diet do you eat?
Well, I can eat almost anything now.
Anything I'll cook.
Yes, I can cook.
What? Yeah, sorry?
I do go from I was on a liquid diet for probably about 6 months, but you do get used to it, and the only downside was when I had to have the radiotherapy, they have to build you up so that you don't lose weight. So having got to probably slim, as I was in my mid-20s when it all the story started, with all this radiotherapy, and they kept assuring me, don't worry, you'll lose it. They wasn't telling the truth. So, and here I am today. I've had a few minor problems, but on the whole, I think I'm probably one of Iain's success stories, I hope.
Do you want to tell us what it was like looking after Laura?
Oh, it was quite all right as it happens. Like, you know, it wasn't any different really to anything. Like, you know, I had to sort of when she had a leg implanted, you had to help them about and then do a bit more cooking or doing something which she couldn't do, like sort of thing. Like, but she didn't like my cooking anyway. So, normally she was quite good. Like, you know, there wasn't nothing good at all. Like, you know, it wasn't anything out of the ordinary where I had to sort of carry her to bed or anything like that. Everything she wanted to do herself. She was, you know, domineering. And I'm going to do that. I'm going to go up there and do this myself. Like, you know, the only thing I was a bit that was the nurses that come in to look after her leg afterwards when she had anything, because it was all like it was festered up like sort of thing. Like, I know it's nothing to do with the hospital, but they seemed to come in and she'd take the dressing off, and it'd be like a nice dry sort of form scab on it. You know, so I thought, that's ideal. That stays on it and it just falls off, and that's it. She used to come and get this disinfectant stuff, you know, stuff that's infected full stuff. Go like that and rub it off.
But in fairness,
rub it right off again, then put another one back and do it every day. So it was wet every day.
Yeah, but
we're never going to get dry like.
Yeah, but in fairness to them, they'd never seen that before, so you can't really blame nurses.
No, they've seen scars.
Anyway, that is my story.
Okay, do you want to ask some questions? Yes, go ahead. Go.
Where was the foot fitting?
Well, she had a fibula flap.
So
Well, probably I'm not seen it before, but a claw foot.
Yeah.
So, did she have some kind of ischemia of the tendons on the plantar surface of the foot that caused that clawing effect? I don't know whether that was the case, or whether did she have some nerve damage that caused that when the fibula was taken. I'm not sure.
No, I think he did say that possibly blood had dripped onto it, and
Yeah.
I don't think they really knew
Yeah.
what had happened,
A
to be honest.
difficult problem, yeah.
Did you drink or smoke or anything when you were sort of
I did used to smoke in my younger days, but as soon as I got the problems, then I stopped.
What he done was the doctor told her, explained to her in hospital about her jaw, and she came out, and she'd smoked the fag for just before in the morning, and she hadn't no more. So when we come out, I said to her, before you jump in the car, run across, get your packet of fags. She went, I'm smoking no more, and she never smoked since. She's never smoked since that day.
No, I
Never.
just didn't. Yeah, so the answer to that question is I did smoke. Though whether or not, well,
No,
we all know.
we don't know the link between that, so you can't blame yourself over that. Any other questions? Yep.
do you have any pain at the moment?
Did I?
Do you have any pain?
Do you have any
No.
pain? No.
Do I have any pain now? Yeah, I do, not constantly. When I wake up in the morning, my jaw's stiff. I think probably that's probably the damage from the radiotherapy.
Bound to be, nothing to do with the surgery.
No, because I don't recall after the operation, surprisingly enough, having any pain. But I did quite a bit after the radiotherapy. And when I first woke up, I had to kind of get the jaw moving this side.
Can you show us your tonsils?
Pardon?
Can you show us your tonsils? It's a polite question.
I can open it quite well now.
So you had complete jaw transplant. Was it with artificial?
With
okay.
fibula.
Yeah. Okay. And then, so how long after did you get the implants, or how long did it take before they got the implants?
Well, there was a delay. Well, Andrew put them in before the. Well, he put some in before the radiotherapy. He had to get permission to do that. I don't think they were very happy to do that. I didn't want him to, but eventually he did. So I had the operation, Iain performed the operation in, I think, the 9th of September. I didn't.
You sure it wasn't the 10th?
No, it's
Okay, I'm just teasing. The patients always remember the day.
the 9th of September.
What time was it at though?
No.
Come on.
It was
7 o'clock.
What was the
seven o'clock in
weather
the
like? What do you know? Was it
7
raining?
o'clock
Was it
in the
sunshine?
morning.
You know, come on, let's have a
And
bit
the
more
porter,
information.
can you believe this? The porter put me on the stretcher and wheeled me out of the ward, and everybody in the ward waved to me. And I went down and I thought, where is he taking me? And he went down, I think I probably know every corridor of Barts. But then he said, I know this is quite strange, but I'm going to take you on a shortcut. And he took me into this warehouse place, didn't he? With all filing boxes and old beds. And I thought, I'm dreaming, this is not really happening. But he made me laugh so much that when I actually got to the theatre, we was all laughing, and I think when I sort of came in, they were all quite surprised.
That's another good point. Unfortunately, in a big institution like this, we really don't cherish and nurture these wonderful staff. There are some absolutely brilliant porters here who really give their lives to it. They don't earn a lot of money. They keep patients happy. They keep them jolly as they're walking along.
Oh, they were fantastic.
They're just the most wonderful people. You know, one of them's offered to take me to Jamaica, to his farm, where grows things. They're all salt of the earth. They're all delightful people, and they're just really not nurtured at all, not cherished, and it's just a real tragedy.
Yeah.
And I'm thrilled you tell that story about that porter because they're all like that. They're
Well,
all
they
just
were. I've got to
gorgeous
say,
flowers.
in that ward, everybody that was in that ward, and there were two nurses in particular, two Filipino
Well, the
girls,
Filipinos are gorgeous. They're
and
fantastic.
one of them now is in Australia. She still emails me. She still sends photographs and of her little girl, and they were just magnificent. With the other operations I had in between, I did go into a couple of private hospitals. One I got MRI, one. The staff weren't as good as what they were in Barts. I just felt safer in there because I had people there that were highly qualified. I felt safe. I had confidence in them. I had confidence in Iain, and I think that is the most important factor of all. And
The problem is our senior management really, the point about a hospital is, it's all about, or the point about the health service is, it's all about the staff who work in it. And when the staff aren't cherished, and when they're not rewarded when they do well, when they're not chastised when they don't do so well, then, you know, why is there any incentive to do well? And so you end up with lots of hospitals where the staff are disempowered, don't enjoy their work, don't enjoy coming in, so they don't come in a lot, so you have sickness and things like that. That never used to happen. And it's the managerial culture. The trouble with the management in the health service is they're really only in place for 2 years and then move on somewhere else. They have no strategic vision for the place where they are, they have no commitment to the place where they are, and they have no commitment to the staff who make the place run. And that isn't the surgeons, that's the porters, that's the receptionists who you see at the desk when you come in, that's the secretaries. Those are the people who really keep the place going.
Another important thing that I did forget, I think the day or probably the day or 2 days before Iain was going to perform the operation, he did explain all what could happen, and I did ask him, you know, where he was going to cut and etc., etc. And he did say, I might have to cut here, you might lose your hearing, I might have to cut further back, and so he gave me the worst scenario. So when I did, actually, it's quite a while before they let you look in a mirror, but when I did see the job that he'd done, I just thought, what a miracle man he is, because I still have my ears, I still have my hearing. No, I'm not convinced. He always says that it's not as good as it was, but I often but that's selective hearing, I think. And as you can see, he's done a really neat job. So
Slit her throat.
so
You told me that, didn't you?
Yeah, yes, she said you're the only man she talks to now to slit her throat.
so that's my story. Any other questions?
So it's wonderful that we have the facility to reconstruct a whole jaw. So, I mean, I'm sure you don't look at Doreen and think she's had pretty well all her jaw removed. Would you look sideways at her when she walks along the street? No, probably not. You know. So the point is, would you think she can eat a normal diet? She can speak normally? You know, I mean, it's the wonders of modern surgery. And I'm very lucky to be in this age. And what's bizarre to me is that I first started working in 1973, and so that is 40 years, isn't it? Nearly half a century. And I think oh, there have been immense advances over this time. And then when I say actually it's over 40 years, I realise that actually you'd expect a few advances to be over 40 years. Because when you get to my age, you don't actually think that you're old. You still think you're young, but you know, it's your body that tells you you're old. Anyway, anybody else want to ask any other questions? Okay. Do you want to ask any questions about Professor Piscotty? Or do you want to just Google her and follow her every movement, stalk her, and make sure that you do PhDs with her and that you change the world for the better, so that in 40 years' time you can look back and say, I worked with Professor De Silvio and I changed the world. Anyway, thank you very much indeed.
Yeah.
Thank you.